Hello, everyone. I'm Dr. Khaled Emara, professor of orthopedic surgery. I will explain to you our technique in treatment of Perthes disease. Basically, we published this paper internationally in 2023, so that was 3 years ago, with a very long-term follow-up, 15 years or up to 20 years follow-up of our patients. Basically, as you already know, Perthes disease is a deformity at the upper end of the femur, the head of the femur, secondary to temporary obstruction of blood supply. This deformity brings an osteophyte. This osteophyte or this prominence, the common sense is to bring this osteophyte away from friction inside the acetabulum, not to bring impingement inside the acetabulum. That's the common sense, right? But unfortunately, some people say, no, we are doing something different. We're doing what's called containment, either by abduction brace, which already proved to be not effective and doesn't help the patient. Why? Because remodeling of the head takes at least 1 year, or even more to regain its shape. So you cannot put a child in 24 hours abduction brace or a cast for 2 years. And containment is a good idea in treatment of DDH, not in treatment of a deformed head. So in Perthes, this is a circular normal head, but in Perthes, there is a deformation and osteophyte. And this osteophyte, it is better to bring it away from the hip, not inside the hip joint. So we published this paper. You can find it on PubMed and with a very long-term follow-up. And I will show you our technique. What basically the patient is coming you to complain about is the limb length discrepancy, the pelvic obliquity with the associated low back pain, the hip pain, the knee pain, the Trendelenburg gait because of the abductor insufficiency. But this patient doesn't get osteoarthritis of the hip according to literature, except after age of 50 or more. That's in most of the literature. So what we do is basically we do CT scan before surgery. Then intraoperatively, we do hip arthrography to find out where exactly the osteophyte, because the head is made of cartilage that doesn't show up in the X-ray, and calcified bone that you see it in the X-ray. And after knowing where exactly the osteophyte, we do an osteotomy to rotate the head, trochanteric or subtrochanteric osteotomy. So we bring the friction away from the acetabulum, not inside the acetabulum. So you are not creating a femoral acetabular impingement. But on the other hand, some people say we do varus osteotomy. It worked well. Unfortunately, varus osteotomy make the Trendelenburg worse, the limb length discrepancy worse, and if really you are doing a head that is deformed and you are pushing the osteophyte inside the acetabulum, that doesn't make sense. So most probably, people who do varus osteotomy and say we got a good result, they did it for a patient with a spherical head, a patient that doesn't need surgery, but they didn't know it because they looked at the calcified tissue, but they didn't do arthrography to see the real cartilaginous coverage. Some other people say we do pelvic osteotomy for containment. You are treating the wrong side of the hip. The pelvis is the normal side. The acetabulum is the normal side, but the head is the deformity. The other thing is if you are rotating the acetabulum to cover the head, you are pushing the osteophyte inside the acetabulum, which doesn't make sense. You are creating osteoarthritis, not preventing osteoarthritis. Some others will say we do unloading or hip distraction. And also that doesn't make sense because if you put an external fixator for 1 month or 3 months or 4 months, that's not enough for the head to remodel. The head to remodel, it takes 1 year, 2 years, 3 years. So you cannot put an external fixator on a hip for 2 or 3 years as a hip distraction. And that's why we get pentract infection, stiffness, and the happiest day in the child life is the day of removal of this cumbersome stuff. And it doesn't help at all. And we already published also these bad results. So what we do is we do hip arthrography to stage the head and find the Stillberg classification to find out where exactly the osteophyte is. And we do our surgery at the fragmentation stage when really the deformation stopped, and this is the final shape of the head. So we know where the osteophyte is and will be, and we do the osteotomy. And this is part of our paper. We do arthrography and do the osteotomy to bring the osteophyte away from the acetabulum. And we have, as you see, a very long-term follow-up, 15 years and 20 years, with completely normal head and completely normal person doing everything. And actually, some centers now are adopting our technique, the valgus osteotomy, for Perthes disease and proved the same outcome, the great outcome and the benefit for the patient. For example, this paper that was published recently in Clinical Orthopedics and Related Research, a multi-center study in Korea, Australia, and India. And they proved that they used our technique, the hip arthrography and the valgus, to bring the osteophyte away with a long follow-up and prove the same outcome, which is excellent outcome. That's why we do this technique. We don't do the pelvic osteotomy technique or the varus osteotomy technique or the unloading and hip distraction technique. I hope you make benefit from this paper, from this technique, to help our patients and to make sure that you are really doing a beneficial surgery, not doing a surgery for a patient that he or she doesn't need it, or do the wrong procedure for the disease. Thank you very much.